started taking meds. So he was an adult basically, understood it.
Yeah, he knew what to expect.
Yes, he did. So,
You want me to just go?
yeah, I can do a whole thing.
Thank you all so much for coming to our Parkway Mental Health Night tonight. We have Dr. Chad Sylvester here from Washington University on the topic of anxiety and ADHD. So we really appreciate you taking your evening to learn more about that. And Dr. Sylvester, we appreciate you as well for being here. Just a housekeeping thing, if you all should need the bathroom, they're just right outside in the hallway on both sides. So if you need that, feel free to use those facilities. But otherwise, take it away.
So the mic is on. It's okay if I walk around for a little bit. How you guys doing? Thank you for the introduction. So, as was stated, my name is Chad Sylvester, and I am a child and adolescent psychiatrist at Washington University. I have I focus specifically on childhood anxiety disorders. So, I have a specialty clinic that focuses on kids that are pretty much anybody younger than 18. I see in my clinic that focuses on anxiety. I also see a lot of ADHD, and so those are the main things that I wanted to chat about today. One thing to keep in mind is that this is being, so I'm fine, I want this to be useful to people. So if you guys want to interrupt me, raise your hand or just blurt out stuff, that's totally fine. To just ask about clarification or something more specific is fine. Excuse me. Just keep in mind that it's being recorded, so as long as you're okay with whatever you're saying being recorded is one thing to just keep in mind. But otherwise, again, whatever people want. And then I can stick around for a little bit afterwards to answer questions as well, either as a group or otherwise. They told me that this is backwards from what I would expect, so I may accidentally go backwards instead of forward this time. Okay, so I always like to get started just by kind of getting everybody on the same page, and then also start by giving an example of a person that's kind of based off of people that I've seen in my clinic, just to give people a sense of how impairing some of these things can be, and also sometimes even how tricky it can be for us to know exactly what is causing the situation. So Rachel was a 10-year-old girl who came to our clinic for test anxiety. Whenever she starts a test or homework, she becomes overwhelmed, anxious, and says that her mind goes blank. She also gets very angry when asked to do chores at home. She gets into arguments with her parents about doing homework and chores, and sometimes will throw things at her parents or hit them when she gets really frustrated. A couple of different elements here that may point to a few different things that are getting in Rachel's way. And this is sort of the type of person that we might see and try to figure out what's going on, why she's having these challenges with the anxiety and some of this aggression. Okay, so the first part of the talk is really just spent on some background information and definitions just to get everybody on the same page. So the first thing that I want to clarify is that anxiety disorders are a group of related disorders. So, and we try to classify different types of them. And I'm going to get into that in the next set of slides. But just in terms of some basic definitions, in order to have any of the anxiety disorders that I'll talk about, you have to have either excessive fear or anxiety. So fear being you're scared of something that's in front of you, right? It's like something is scary right now and you're currently fearful about whatever that is. Anxiety, on the other hand, is more like I'm worried about things that may or may not happen in the future, right? So it's not something that's currently in front of you, but some possible thing that might go on later on. Of course, everybody has fear and anxiety. These are just normal human emotions. And so in order for it to be considered a disorder or a problem, that has to cause you a problem. And there's no sort of magic line in terms of what makes it become a disorder versus sort of normal, other than if it's causing you a problem, it's getting in your way in some way, then it's probably helpful to address it somehow. The most common way that people react to something that they're fearful or scared of is to avoid whatever it is that they're fearful or scared of, and especially kids will just not want to be around whatever it is that's making them anxious. So avoiding school, avoiding sports, something like that. But there are other ways that kids can react when they're scared or anxious. Another common one being anger or outbursts. And so you kind of have to link when they're angry to the thing that's making them nervous or scared. And then some kids, and some kids don't show either of those things necessarily, but they're just constantly under a lot of distress. They're just constantly stressed out or agitated, even if they kind of keep it all bottled in. And we would still consider that to be an anxiety disorder if it were very distressing to them. Okay, so I mentioned that there are different kinds of anxiety disorders, and when we evaluate kids in the clinic, we try to comb through different types of anxiety to figure out exactly what is that particular kid's trigger. And I'll get into later on why we think that's really important to be able to, one, understand where the child may have problems, and then two, to design a treatment plan for that child. So the first type of anxiety disorder that commonly comes to clinical attention in kids is called separation anxiety disorder. And the common fear that a child with separation anxiety disorder has is that they're worried that something bad is going to happen to them, or something bad is going to happen to their caregiver or parent whenever they're separated. So the most obvious way this would come up would be if a kid gets dropped off at school and they don't want to leave the car or whatever because they're scared that if they go into school that there's going to be an intruder or something bad is going to happen at school. The parent's going to get into a car accident and they're not going to be able to pick them back up later on. But sometimes kids can feel comfortable going at school. They have maybe a teacher that they like, and so they start to feel comfortable around that person. Other ways that separation anxiety can show up is at nighttime. So a lot of kids with separation anxiety disorder don't want to sleep in their own bed. They'll climb into bed with their parents, or they'll leave their parent to be in there until they fall asleep. Other ways that it can come up are just a kid doesn't want to be by themselves at home, either in the house by themselves or even just in a room by themselves, unless they're like heavily distracted by maybe like by an iPad or a tablet or something, but don't want to be alone. And again, it's because they're worried someone's going to break into the house and kidnap them, or they're worried something bad's going to happen to mom or dad whenever they're separated. So that's one type of anxiety disorder. Another type of anxiety disorder that commonly comes to clinical attention in kids is social anxiety disorder or social phobia. In this case, the underlying fear is that a child feels like they are going to be negatively evaluated by their peers.
I just have a question.
Sure.
So, when you said the child feels scared of things, like going to sleep at night by himself, goes in his parents' room, or all these different reasons. What if they're parents these days are already anxious to send their kids to school because of all the shootings, and there's been so many. What if there is an actual perceived threat?
So
Is it still anxiety?
So the question is, if there is a real threat, would it still be considered an anxiety disorder? And the answer is no, right? So if there's a legitimate reason to be scared, then you don't consider that an anxiety disorder.
So do they have anxiety already?
The qualifying thing I would say about that is that as scary as school shootings are, they're very rare, right? The likelihood that any one particular child is going to, have something like that happen is very low. And so it's a balance between doing things that are, general things to keep you safe, but still kind of going out in the world and taking advantage of things you can do, even though there might be a minuscule risk of something bad happening, right? So if a child had an excessive fear, say, coming here, that they, didn't want to come to school, we would still consider that to be separation anxiety. It's more that if, you know, they're being bullied at school, say, right? Like they're getting beat up every day. Then that would not be separation anxiety, because then they have a legitimate fear that's realistic, right, of them of being hurt. So. Social phobia, the underlying fear is fear of negative evaluation from peers. And so the most common way that this comes up in kids is they're excessively shy, right? So it's normal when a kid first goes to school that they're shy the first few days, they're getting used to their new classroom. But if they just don't talk for long periods of time, for months, and they're worried, it's because they're worried what other kids are going to think of them, then that would be social anxiety. So again, shyness is the most common way this comes up, but the other ways in which we see social phobia arise is in activities. So a lot of kids with social phobia won't want to play sports or do other kinds of activities because they're worried that they're going to screw things up for the team, or they're going to stick out and perform poorly, and everyone's going to think something bad about them.
So we've heard, so if you're exposed to something you're scared of again and again, it goes away. So say a child who has to go to school and is afraid to go to school, but every day he still goes. So would you still diagnose it as anxiety?
So the question is about if a person still does something, could they still be anxious around it? And the answer is yes. So the most common thing is avoidance. But there are other ways in which you can have a behavioral disturbance. That was from the previous slides, where you can get really angry or just distressed a lot of the times, or it can come out in some other way. So maybe the kid's anxious all day, and then they come home and they just like unload on their parent, right? Because they've just had all that tension all day. So there's other ways in which it can come up. So, and then you know, obviously things like raising your hand in class or talking in front of the class would be other ways in which social phobia could come up. But again, the underlying fear is fear of negative evaluations from others. And then the third type of anxiety disorder, this is the last one, that commonly comes to clinical attention in kids or adults, is generalized anxiety disorder. So these are kids that are constantly worrying about something. And what it is that they're worrying about might change from day to day or minute to minute. So they're thinking about things that are going to potentially happen in the future, but you know, it might not go right. You know, are we going to get to school on time? Are we going to, you know, there are going to be too many lights? Is there going to be too much traffic? You get to school, oh my gosh, what's it going to be like today? Did I have to pack everything in my backpack? Like, what if this happens? What if that happens? You know, what if there's a storm, right? What if, you know, some more general kind of fear keeps popping up? And for a lot of kids and parents, they get into this dynamic then where the kid is worrying and then the parent reassures them about something. I know, it's going to be fine. We left plenty early. The kid feels better about that, and then they start worrying about something else. And so the parent then has to reassure them about that. And it can be just this sort of like constant sort of thing. So it's not one thing in particular. And this one is supposed to be associated with a physical symptom like stomach aches or headaches, but the truth is that that can be involved in any type of anxiety disorder. So quick clarifying question?
Yes. So what I was asking before, when you get exposed to your fear again and again, have you seen it reduce in your pediatric patient?
So the question is about if you're repeatedly exposed to something, would it go down? It's a great question, and that's going to come up a lot in the second half of the talk. So I'll get to that. If I don't, let me know, but I will. Okay. So the most common, so those are the three types of anxiety disorders that commonly come to clinical attention in kids. But like the type that would come into my office. But the most common form of anxiety disorder is actually specific phobia, which is being scared of something very specific, like dogs or getting in blood or flying or heights or something like that. I don't spend a lot of time talking about it because it tends to often be so circumscribed that we don't see a lot in like specialty clinics like my clinic. But all the principles that we'll talk about today will also apply to the specific phobia. Okay, So those are just the types of anxiety disorders that we commonly see in kids. And then I wanted to talk briefly about ADHD as well. So ADHD stands for Attention Deficit Hyperactivity Disorder, and kids with ADHD can have either one or both of these categories that I have up here. So either inattention or hyperactivity slash impulsivity. So kids that have ADHD, the inattention things are pretty straightforward, right? They have a hard time staying focused, say in class, listening to the teacher. They're easily distracted, say, by something else that's going on around them. Having a hard time staying organized, right? So keeping track of all the assignments that they have. A lot of times kids with ADHD will either not complete an assignment or forget they have to do it, or they'll do it, but then they'll forget to turn it in. So just general kind of organizational type stuff. They often also tend to avoid things that take a lot of mental effort. So if you, imagine if, for those of you that don't have ADHD, imagine that if you needed glasses, but badly, but you didn't have them, right? And you needed to read something. Like if you squinted, you probably start to get through it, right? But you wouldn't be able to maintain that effort for hours and hours. And so you probably would avoid reading things when you didn't have your glasses. It's kind of the same experience for kids with ADHD, right? Like just they know that it's going to be so painful to spend all that time doing something that they tend to avoid doing it. And then the other part of ADHD is the hyperactivity impulsivity. And so these are the more sort of obvious kind of trouble-causing symptoms where kids can be kind of squirmy or need to get up and move around. They're kind of always on the go like an Energizer bunny. This can also come up with verbal, so they're talking a lot or want to interrupt people or change the subject suddenly to things that are kind of not really related to what you're talking about. Troubles taking turns. And then the other thing that's kind of under-recognized is kids with ADHD will also often, their moods will change very quickly. So they have impulsivity of their mood. So impulsivity being they kind of act quickly without thinking, right? So do something and then maybe even regret it later because they just didn't kind of think it through. That same sort of thing can happen with emotions with a kid with ADHD. So they can get suddenly really angry or really happy in response to things, and then the mood can change kind of quickly from sort of event to event. Okay, so any questions about just our basic definitions and what these anxiety disorders and ADHD look like?
Yes, I have a quick question about the social anxiety. You say that you see children avoiding sports and activities. At what age do you see this? Is it from the very early age, or it shows when they really understand that people judge them? Because when they're young, let's say 5 or 6 or 7, they do not really understand that, right?
Yeah, that's a good point. So we're actually going to talk about the average age of onset of some of these things, but the specific question about whether or not a 4 or 5-year-old could have social anxiety, you may not call it social anxiety at that point, but certainly you can see kids that are really reluctant to kind of engage with other kids because they're kind of nervous or scared, even if they can't necessarily put articulate or explain why it is that they don't want to be around those other kids. You have to be a little bit careful because sometimes kids don't want to be social for other reasons, right? So another reason that's more rare would be something like autism, where people just aren't in general as adept, or they aren't as good at interacting socially, and sometimes can just not be as interested in making friends and things like that. So there are other reasons why a kid that's 4 or 5 may not, be as social or want to do sports or other things like that. But one reason could be early symptoms of something that's going to eventually develop into social anxiety. Does that answer your question?
Yeah, and do you diagnose kids at 6 or 7 with anxiety, or the diagnosis comes later?
So we could, yes, and especially things like separation anxiety, but even generalized anxiety. Obviously you have to adjust how you make the diagnosis depending on the age of the kid and what they can understand. But if a child is really impairing, say that they're, you know, in 5 years old, they're starting kindergarten, and they're so socially anxious that they won't talk with any of the other kids, then, and that's keeping them from learning as much as they might, or wanting, maybe they want friends but they can't make them, then yes, we would still diagnose them with social phobia at age 5. But it's mainly just to be able to describe to other people where the challenges are coming from, right? So, you know, and then you can decide how you're going to help them with that, right?
Thank you.
Well, I accept that just a general comment, but I have a son that has just, like, he's at 10 or 11 years old, actually verbalized to us that he's nervous. So at that age, then you know. But I guess when they're younger, they don't know, because I didn't know either. So now we know.
Okay.
Yeah, and that's how we found out. But I just wanted to say a general comment that it's interesting that you're talking about both ADHD and anxiety, because we had a son who was diagnosed with ADHD, and I started thinking that maybe he also has anxiety, and I didn't know that you're probably, I don't know if you're gonna talk about how they're kind of related or not. So now we're medicating him for both, but then I don't know if I should just be medicating him for anxiety, but the psychiatrist had said to keep going with his ADHD medication and the anxiety together, and so we're hoping that that works. But
Yeah, so thanks for bringing this up. So I'll kind of repeat stuff for people that are on YouTube. But the question or the statement is about having both anxiety and ADHD, and what's the source of the symptoms, and should you treat both at the same time or pick one or the other? And this is a common challenge that we have. So yes, so first, if you have one, you're more likely to have the other. So they are some commonly what we call comorbid. But we see everything. We see kids with just anxiety, just with ADHD, and both. The example that I gave at the beginning was actually meant to be difficult at first to know if it's anxiety or ADHD, because a kid that has test anxiety could have generalized anxiety, they could have social anxiety because they're worried that how they're going to perform and how other people are going to view them, or they could have ADHD because they know that they can't take the effort. So we have to kind of comb through different scenarios and understand all these different things that are coming up in order to come up with our best guess. And then sometimes it's both, right? So so thanks for bringing all that up. Okay, so the first kind of then, beyond the definition, general education points that I want to make. The first thing is that anxiety disorders are very common. They're the most common form of mental health problem at any age, adult or child. The exact numbers depend on how we measure it. So who we ask, if we ask the kid, if we ask the parent, if we're doing it versus people are just filling out a questionnaire. This study has the overall rates of anxiety disorders to be pretty high, like 30%. It's probably closer to like 10 or 20% if you increase like how severe it has to be in order to call it a disorder. But however you measure it, anxiety disorders are always the most common. So they're more common than ADHD, more common than depression, more common certainly than things like autism or schizophrenia or other things like that. ADHD is also pretty common. So you see here it's listed at 8%, probably somewhere between 5 and 10% of kids have ADHD. So out of a class of 30 kids, probably 5 or more might have either anxiety or ADHD or both. The next point that I want to make is both anxiety and ADHD, if you're going to have these challenges, they almost always start when you're young. They almost always start in early childhood. So the median age of onset of an anxiety disorder, so that's the age by which half of all people that are ever going to get an anxiety disorder, get their first anxiety disorder, is between like 6 and 8 years of age. So most adults that, or even teenagers that have anxiety, it started in some way when they were like 6, 7, or 8, to kind of to your question earlier. The exact age of onset depends on the actual disorder. So separation anxiety disorder starts to come up when kids are needing to leave their parents, right? Go to preschool, go to elementary school. Social phobia, we start to see more of that happen once social relationships become more important, so usually more around like late elementary school, early middle school. And then generalized anxiety disorder is more often around like high school and early adulthood. But these are just averages. So we see 6-year-olds with generalized anxiety disorder that are worrying all the time. And this is the age of onset of your first anxiety disorder, right? So, but it's not uncommon for kids that have separation anxiety to be the same kid that then develops social phobia as they get older.
Do
ADHD,
you know how many, like what's the percentage of like, in a normal classroom, how many kids are getting anxiety these days?
so the question is in an average classroom now, how many kids are getting anxiety? And it's a really tough question because it depends so much on that classroom and how we measure it. But our best guess of sort of like really impairing anxiety would probably be around 10 to 20%. So 1 out of every 5 to 1 out of every 10 kids. For ADHD, it used to be that in order to get a diagnosis of ADHD, you had to have all the symptoms by 5 or 7 years of age. Now that's been modified as people have sort of recognized that you can have adult onset ADHD or middle onset. But again, most people that get ADHD, it tends to start when they're young. So these are reasons why we want to identify it when it's first starting, right? When kids are first getting these things. Okay, so I sometimes get asked the question, well, what caused a child to have anxiety? It's sort of similar to some of the questions that were being asked earlier. And it turns out that anxiety is probably 50-50 genetics and what happens to you. So genetics and environment, right? What you're just kind of born with, and then what happens to you over your life. The genetic influence we think we can see even sometimes very early. So there are in my lab we study. I also run a research lab, which we'll talk a little bit about later. We even sort of evaluate kids when they're 4-month-olds, 14 and 24-month-old, and put them in different scenarios where they have to like meet a stranger or crawl through a tunnel. And some kids, even at that age, will be like freeze up and be very shy in those situations. And we call that being behaviorally inhibited. And that's the strongest known risk factor that we have for later development of an anxiety disorder. The point being that some of the signs are already happening, can already be seen very early in development. But then another portion of it is sort of what happens to you over the course of your life. And one of the biggest environmental influences on a child is their parent. And so parents, we think, can have some level of pushing or pulling. And so I want to be clear that I don't think that parents cause their children to be anxious, right? There are lots of kids that are going to be anxious no matter what their parents do. And there are lots of kids that are not going to be anxious no matter what their parents do. But there are probably, some kids in the middle that maybe you can just at least push them a little bit one way or the other. Not make it maybe a huge change, but you can kind of nudge them a little bit. And so I just want to kind of give like oversimplified examples of parenting styles that are associated with continued problems with anxiety versus sort of likelihood that maybe it will get a little bit better. This is not meant to be like one size fits all, it's just an example. So imagine that you have a child that is scared to go into school. Say they have separation anxiety. And so Johnny gets out and says, Mom, Dad, I don't want to go to school today. So the parenting style that is least associated with that child continuing to have a problem with anxiety is called authoritative parenting, where the parent is warm but in control of the situation. So that parent might say something like, I can see you're really scared, Johnny, and I'm sorry that you're feeling this way, but you have to go into school today, right? So the parent is validating what the child says. They're helping them understand that it's anxiety, what it is. They're saying like, yeah, it's no fun to be that way, but they're also saying you still have to do whatever it is that you're supposed to do. So that's associated with that child's symptoms kind of getting better over time. The other extremes then are associated with that child continuing to have a problem. One extreme would be what's called authoritarian parenting. So that parent might be in control, but kind of cold. And so that parent might say, stop being a baby, Johnny, and get into school, right? So that parent is in control, they're saying you have to go do it, but they're not helping the child validate, the child's not able to understand and kind of sort of process the emotion in a sense. And then the other extreme would be more like passive parenting, where the parent may be warm, but they're not as much sort of kind of in control. And that would be, oh yeah, Johnny, you're overwhelmed. Let's go home and we'll just try again tomorrow, right? And so the challenges we'll get into with that last style is that the child learns an effective way of managing their anxiety. Because the child goes home, they're not anxious anymore, and so their brain learns, oh, this is how you are not anxious. You just don't do whatever it is that you were scared of, right? It's reinforcing the avoidance. Again, this is an oversimplification, right? I'm not saying that every situation where a child is nervous, you should force them to do it, right? But that's the general idea. Okay, so, most kids, anxiety and ADHD are very common. Most kids that have anxiety or ADHD do fine when they're adults, right? They often will just sort of, things will get a little bit better, or they'll just kind of figure it out and they'll craft their life in a way where the symptoms don't really cause them problems, right? So if they have social phobia, they might not want to do something where they're interacting with other people all day, or something like that. That being said, if you take two kids, one that has, say, an anxiety disorder or ADHD, and one that does not, the kid that has anxiety or ADHD is more likely to have a host of problems when they become an adult compared to the kid that doesn't, right? So the point is, most kids do fine, but they do have increased risk compared to other kids. Does that make sense? So for kids that have anxiety disorders, as they get older, they're more likely to continue to have problems with anxiety than other kids. They're more likely to have depression. So depression is an illness where people are sad or don't enjoy things, and that can last for weeks, and then get better, and then come back. So most adults that have major depression had an anxiety disorder when they were a child, right? So kids with anxiety are more likely to eventually become depressed. And I see a lot of kids in my clinic that were anxious when they were young, and then sometimes that can turn into depression. They're more likely to abuse substances, nicotine, alcohol, etc. And then they're slightly more likely to kind of not get as far in school and have higher unemployment rates, although the truth is that there are other factors that are way more important than how anxious you are. For example, your socioeconomic status would have a much bigger influence on those things than the level of anxiety. For ADHD, it's sort of the same thing. So kids with ADHD are more likely to develop depression, substance use disorders, other types of psychiatric problems. And then people with ADHD are also untreated, are more likely to sort of have their lack of focus or their impulsivity cause them major problems, like getting into car accidents, using drugs, those sorts of things. And in fact, slightly increased risk of death from some of those things. And so you can imagine if you're driving and you have ADHD, right? Like you're just more likely to get into a car accident, etc. Okay, so this is the first half was mainly just to kind of get everybody on the same page as far as anxiety and ADHD and what their kind of their major characteristics are. They're very common, both of these things. They often start in childhood. They almost always start in childhood, early childhood. Most of the kids that have ADHD or anxiety do fine, but they're at increased risk compared to their peers for some of these other kinds of things happening. And then the flip side being that most adults that have a psychiatric problem had ADHD or anxiety when they were a child, which is one of the reasons why I got into child psychiatry and I try to help kids when they're young, is that we hope that by helping them when they're young, that we can prevent some of this other stuff from happening. We don't know for a fact that that's true, but it seems to be the case in some instances at least.
Apart from medicine, is there another, because many times parents don't want to give medicine because you hear so many things about like medicine, like what do you call it? Negative symptoms or positive symptoms, whatever you call it. So what other, will you talk about
Yes, I'm going to talk exactly about that. So the next half of the talk is about treatments, and we're going to cover both medication, but mainly non-medication treatments, actually. But we'll go over all that. So let me know if by the end of this stuff there's anything that we haven't covered. Okay. So, what are the best evidence-based treatment options? So I'm going to start with anxiety. So, I spend a lot of my time doing research, so whenever I'm trying to decide what treatments I'm going to recommend for a child, it's based on science, it's based on the literature, it's based on decades of work. There are many studies that ask the question, how do you help a child that has a problem with anxiety? And I'm going to show you the largest one, but there are many studies that show the same thing. So for this study, there were almost 500 kids, 4 or 5 different universities across the country. They had to have, in order to be in the study, they had to have either separation anxiety, social anxiety, or generalized anxiety, the ones that I mentioned. And then they were randomly assigned to either just get a medicine, just have therapy, get both, or like 12% got a sugar pill, got a placebo. So essentially no treatment. And the results were pretty straightforward. So for kids that just got that sugar pill, placebo, about 25% of them, 12 weeks later, said they were improved or very improved. If they got either medicine or therapy alone, about 60% of those kids were improved or very improved 3 months later. And so either medicine or therapy were effective, more effective than doing nothing, and more than getting this placebo. But they were not different from each other, so they were equally effective. If they got the kids that got both medicine and therapy, about 80% of them were doing better. And that was better than just getting just one of the 2 treatments. So pretty simple, pretty straightforward. Medicine and therapy are equally effective for kids with anxiety. The combination is better than either one alone. And the way that we use this in clinic is for kids that come in with, say, mild to moderate levels of anxiety, we usually recommend they start with therapy because there are skills that they will learn that we think will be useful lifelong, and we can save them from having to be on medicine. For kids that have more severe anxiety, we will start with both sometimes after a conversation if that's the right thing to do. And then rarely we will start just with medicine. That's usually in the case where there's some reason the child can't do therapy. For example, they're so overwhelmed with anxiety that they can't even start it, and so we put them on medicine first and then try to get them into therapy later on once they're at least have the edge taken off of their anxiety. Or if the child is maybe very depressed, we might wait for the depression to get better with the medicine before moving to therapy. So actually, so really briefly about medicines for anxiety before we talk about therapy. So the medicine used in this study was sertraline or Zoloft, which is a selective serotonin reuptake inhibitor. So for kids with anxiety, we give them medicines once a day, like these SSRIs, like Zoloft or Prozac or something like that, where their anxiety kind of gets better over weeks and months rather than like immediately in that moment. So we tend not to give kids medicines that immediately take their anxiety away. It's like things like Xanax or Ativan or Klonopin, and we'll talk about some of the reasons later. But even just the study suggests that kids don't respond as well to those, and it can actually make them depressed over a long run. But we'll talk about other reasons why we don't do that. But I'm not going to talk anything else really about medicines for anxiety other than that, unless somebody has a specific question. Okay. But I'm going to spend a little bit more time talking about therapy. And the reason that I want to talk about therapy is because, I think that you can kind of pluck some of the stuff that we do in therapy for kids with anxiety as sort of best principles for maybe how to help a child with anxiety of any level. So maybe your child has like a little bit of anxiety, but you're not sure it rises to the level of an anxiety disorder. You could use some of this stuff here anyways, and it's likely to help them even if they don't have a full-blown anxiety disorder. So the first thing to say about therapy is that saying that your child or you are going to therapy is the same thing as saying they're taking a medicine, which I mean to say it's not specific. So just like there are many different types of medicines, they all do different things, there's many different types of therapy and they all work in a different way. So there's lots of different types of therapy. The specific type of therapy that has the most evidence for anybody with anxiety, adults or kids, is called cognitive behavioral therapy, or CBT. So if you have a child that's anxious and you're seeking out therapy, I strongly recommend that you specifically ask for cognitive behavioral therapy with exposure, unless there's some other reason not to do those. So the way that cognitive behavioral therapy works, the other thing is that therapy is really meant to be time limited. So it's really was not originally meant to be like you kind of go there every week, kind of just talk about what happened the last week and sort of like a friend, and then you kind of do that for months and months or whatever, without a goal. Really the original way it was planned was to be, you have a specific kind of plan week to week, and it's meant to be several months where you're going to kind of go through this process, and then you kind of reevaluate whether or not you met your goals at the end of that therapy. So for cognitive behavioral therapy, it's really kind of, we thought it'd be splitting into two halves. So the first half, say it's like a 12 or 16 weeks, so maybe the first half of those weeks, the child learns how to sort of just in the moment, like really understand like their thoughts, their feelings, their body sensations in the moment in which they become nervous. So kind of back again to this idea of when can a child like learn to put words to what they're feeling and describe all of that. So a lot of times people focus on behaviors, right? You need to, like, I don't want to go to school. You have to go to school, right? Well, everybody goes to school. Rather than thinking about, I'm scared, and I'm worried that, I'm scared to go into school because everybody is going to think that I'm dumb, and my heart races every time I go in, right? So the difference between just thinking at a very sort of surface level about what's driving, you're just describing your behavior, versus getting a child to understand what the whole process is that they're going through in terms of their thoughts, their feelings, and their emotions. And so you have to spend several weeks teaching kids all of these different things and helping them try to learn how to be able to do this. It can be very difficult for some people. You sometimes have to start with like characters in a book before you can move on to say their own thoughts, feelings, and actions. And then you often sort of teach people how to relax in that part as well. Right, so like coping skills or something like that. We'll talk a little bit about coping skills, but I think coping skills are not always sort of the most effective way to really help somebody with anxiety, even though it might seem like it is. A lot of it is the other stuff that we're going to talk about in terms of just all the recognition of what's going on, and then this next part. So the next part is the exposure to anxiety-provoking situations. And this is getting at the question that you asked like maybe a half an hour ago. So, and this is a really key element to the therapy and probably more important than the first part, the thoughts, feelings, and actions part. So in this part of the therapy, what we do is we get kids and their families to come up with a scale of 1 to 10, where 10 is something that's the most anxiety-provoking thing you can possibly imagine, that's still safe and something the kids should do. And 1 is something that's not scary at all. And then obviously 5 would be in the middle, and you have all the numbers. And what you're trying to do is get the kid to work to get something that hits all of those numbers, right? So that they, on a scale of 1 to 10. And then what you do over the next 8 weeks is you intentionally have the child go into those situations, but starting with the easy stuff, with the 1s and the 2s, and then working their way up week to week to progressively harder things. And ideally, when they're doing that, they're using the stuff they learned in the first half, where they're like recognizing what's happening and waiting for that stuff to go away, potentially using a relaxation technique, although again, that's not critical. So the idea is relatively simple. For people with anxiety, you just want to gradually get them used to whatever it is that made them nervous. We'll give maybe some specific examples. Okay, so as I said, it should be relatively time limited. You should have a plan of like these 1 to 10 things and what you're going to do week to week and that sort of thing. We have a specific version we use at WashU called Coping Cat or CAT Project, but that's like the brand, I guess, sort of the CBT. That doesn't matter that much. But the important thing is the CBT with exposure therapy. Okay, so what this slide does then is this slide just maybe gives some general tips about what are like potential ways you could interact with an anxious kid that is totally based on what we do in therapy. Right, which is scientifically shown to help kids with anxiety. So the first tip is to be empathic but firm, and I mentioned this earlier, right? So when you're empathic with a child, what you're doing is sort of that first half of CBT, right? You're saying, I can see you're really scared. I know you're telling me that you're thinking that other people are going to judge you. You're telling me that your heart is racing, something like that, right? You're helping them understand that, and you're sort of empathizing with them that that's not a comfortable place to be in. But you're also sort of telling them, and still, even with all of those things, we still kind of do whatever it is that we have to do. And you want to really minimize reassurances, right? Maybe a little bit, or maybe like generally you reassured them the week before or something, that school is generally safe. But the more you reassure a child, the more they're just depending on you to regulate their anxiety for them, rather than them sort of learning through their own experiences that these things are not going to be harmful to them, right? And so it's not bad to reassure your child, I want to be clear. You just want to make sure it's not excessive and that you're not falling into the trap of regulating for your child. The next thing also directly comes from the CBT, so help your child understand their thoughts, their feelings, their emotions. This can be tricky, it's going to take a while. You can start just by asking them, how are you feeling right now? And you can ask them when they're doing well, right? So when they're happy, when they're excited, when they're bored, right? It's just that they get into the habit. You can tell them how you're feeling, or have other people in the family say how they're feeling, right? So that it just becomes normal that you kind of talk about emotions. So coping skills. So again, I don't think coping skills are a critical way to help a child with anxiety, but they could be in some cases, and it's not bad to learn one. But what I will say is that the thing to remember about coping skills is that they're skills, they're not facts, right? So a skill is something that you build up and learn and practice over time. A fact is just like, what's the capital of Missouri, right? And it sounds obvious, but if you see lots of times people will say, well, we told my child how to sort of do deep breathing, and then they had a major meltdown, and we told them to do their deep breathing, and they didn't do it, so it's not working, right? But that's because, again, it's a skill, it's not a fact. You can't just know that that's what you're supposed to do and then employ it in the most difficult situation. Another example that I give is if you just told a child how to swing a baseball bat by saying, you hold the bat up at however many degrees it is, 45 degrees, and then when the ball comes, you drop your shoulders and you hold the bat horizontal, and then you hit the ball, and then throw them into the World Series, right? No, of course not. You would have them practice on a tee, and then with a slow pitch, and you would keep progressing over years and years until you get them to a really difficult situation. So it's the same thing with a coping skill. If you want your child to be effective at deep breathing, then they have to practice it a lot, and they first have to practice it when there's no stakes at all, or the stakes are very low. So maybe at nighttime, before they go to bed, they're practicing doing deep breathing. And then maybe they do it when things are just a little bit challenging for them. And then you keep increasing it and increasing it. Okay, we talked about gradual exposure to fears. Sure.
What coping skills are you talking about that you're saying are not bad? What, give us, what are some, are you saying deep breathing, counting to 10?
Yeah, I'm not saying that they're not that effective. I'm just saying that I think they're in general a little bit overemphasized when it comes to getting a child to learn how to deal with, say,
Are you saying the children?
and adults. Again, if they help in a stressful situation, great. But probably the gradual exposure is more important than teaching a child how to do a coping skill, usually. Okay, so we mentioned gradual exposure to fears, and so, for example, if a child's nervous about going to school, they have social phobia, maybe you would sit in the parking lot with them for a day, and then the next day you kind of like go up to the door. Maybe the next day you're going into the school without anybody else being there. Whatever it is, you kind of gradually break something down rather than having them sort of face like the biggest fear that they have. We talked about avoiding, reinforcing avoidance. Again, we're not flooding kids, we're not making them do something that's 10 out of 10 scary to them. That might be a situation where you don't put them into that, but you kind of gradually get them used to whatever they're scared about. The one thing that's a little bit trickier would be generalized anxiety, where the child is just always worrying about something sort of more nebulous, like there's not something specific. And I mentioned this dynamic that you can fall into where the parent is just constantly reassuring the child. And in that case, what you want to do is help the child learn more how to like not have this process anymore where they keep like going to the parent to get their anxiety lowered, and then it comes back and then it gets lowered again. So in order to do that, one thing that we recommend is having something where the child can worry. So it's, again, worrying actually can be useful. You just don't want to worry all day long, because sometimes that's how you do some level of problem solving or you figure things out. But you just don't want to be all day long worrying, because it would be counterproductive and very distressing. So to teach a child to learn how to contain their worries a little bit more, you can have like a 15-minute worry time each day, where the child sits down with you and they worry, they tell you all their worries, and you reassure them, or you problem solve, or do whatever it is for that 15 minutes. And then if worries come up at any other time of the day, you say, that sounds really important, we'll discuss it during the worry time, right? And you don't reassure them. So the idea is that, again, they just learn a more healthy way of dealing with these things, which is, I'm gonna note that, and I'm gonna let do about it later, rather than go through this not helpful process of just worrying all the time.
I had a question.
Sure.
For the minimal reassurance, my son is 7 and he's got multiple issues. But so what is minimal reassurance for him more reassurance as opposed to a kid that's 10 years old and has it? I'm trying to figure out what is minimal reassurance, basically.
Yeah, that's a good point, right? So what is minimal reassurance? So, the general point is always just to kind of be like aware and thoughtful about what you're doing, right? So if your child is going to be totally overwhelmed and they need you to reassure them in that moment, that's probably the right idea to reassure them in that moment. But you just want to be noting, okay, right now we're at a place where I have to help regulate my child. He can't regulate himself on his own, and so this is, and the more we do this, the more this is going to be a way that he gets reassured. And of course, a little bit of that is healthy and normal. Like we all have relationships that we depend on for reassurance, right? It's just that if you eventually you want to learn, you want to figure out how can I gradually do this less and less and teach him how to reassure himself or regulate himself. So it's more about how do I come up with a plan to get into a healthy situation. So it might start off with, we know that this is going to be totally safe. There's no way, I promise you, whatever you want to say. But then you might eventually move more towards like, we've talked about this a lot. What have I said before, right? So something where you're trying to get that person to then generate it. And then you might eventually move to a point where you say, look, you always bring this particular thing up, and we've talked a lot about it before. So I think I'm actually sort of making this worse by reassuring you all the time. So that, from now on, when you bring up this specific thing, even though I don't like to see you this nervous, I can't reassure you about this anymore, because I think it's just hurting you more than it's helping. But it's a process, right? Okay. So for ADHD, in contrast to anxiety, medicines are way more effective for ADHD than therapy. So it's to the point where medicines are extremely effective, especially the stimulants, things like methylphenidate or Ritalin, or mixed amphetamine salts, or the generic, or the brand would be Adderall, are some of the sort of most effective medicines that we have in medicine, and certainly in psychiatry. So you can have a kid that has extreme ADHD and get them a lot better very quickly with medicine. For therapy for ADHD, we don't really have any known interventions that really majorly or much, hardly at all, impact the core symptoms of ADHD, which are the focus problems, the impulsivity problems, and the hyperactivity problems. So you can kind of help a kid more sort of like maybe learn how to deal with it, which we'll talk about a little bit. You can sort of figure out, okay, given that you have poor focus and you're hyperactive, how can you like structure your life where that doesn't get in your way very much? So you kind of like workarounds or something. That you can do a little bit of, but it's almost impossible. We don't have any clear evidence that you can actually make them easier for them to focus or be less hyperactive with therapy. And we've studied things like neurofeedback, where or video games or other sorts of things. And unfortunately, we just don't have anything right now. Some parent training things can be helpful, but again, that's more like, well, how can I help my kids structure their life so that things are not so difficult for them? And so, what are those things? So the things that can be helpful, again, like teaching workarounds for kids with ADHD, are getting them to work with their say, short attention span, which would be teaching them to do things in small chunks and get small rewards every time they do that, and then go back and forth between that, right? So instead of sitting down for 2 hours doing homework, maybe you sit down for 10 minutes, or you get through something else, and then you get 5 minutes of something different, whatever it is, or you get to pet the dog or something, right? Probably not a tablet, because you'll never get the kid back to home, but you get the idea. When the kids have negative behaviors, you generally, you have to understand their emotions are going to get ramped up, and it's going to be very difficult to get them out of that by sort of arguing with them or saying anything. So usually you want to, in advance, specify what a punishment is going to be for something. Say they throw a toy at you, you've already decided if they throw a toy at you, they don't get that toy for the next week or whatever it is, right? Maybe a day, sorry. Because the other thing about kids with ADHD is there's no real point in giving them a punishment that's going to last more than, say, a day or two, or maybe a little bit longer. Now, you can punish them for several months if you're, for whatever reason, but it's not going to really help them learn any better than if they have this frequent reinforcement, right, where they're repeatedly learning that if they do something, then they get something taken away. The more cycles they have, the quicker they'll learn. Giving them routines, again, like a workaround, right? So I can't focus, but I know that this is what I do in this exact order every time. And if I never change it, then I can sort of make it a habit, right? Rather than having to like flexibly think about how I should figure things out each day. Giving kids specific rather than general instructions. So rather than say, go clean your room and come back in 2 hours, you might have to say something like, okay, go into your room and pick up the stuff that's on the floor and then come back and we'll go to the next thing, right? Like something's very small. That's the breaking big tasks down in small chunks. Obviously minimizing distraction, so getting them in a room or something where there's not other kids or other kinds of distractions, and then giving fewer options when making a choice so that there's not just a lot of different things to do. Okay, so the other thing, of course, that we're always thinking about when we evaluate a child are if there's something else going on. So these are kind of simplified examples of just anxiety or just ADHD. We already talked about that. Sometimes you can have both, or it can not always be clear, which it is. Or sometimes anxiety can look like it causes ADHD. Like anxiety can make it look like it causes poor focus, or poor focus can induce anxiety because you know that you're not going to be able to perform well, and so it can get really tricky. So we always have to look for other things that are going on. We always need to make sure that parents are doing okay. So if a child has a parent that is very anxious, it can be really difficult to actually help the child if the parent's not also getting treatment or getting better. Stress, so if there's a lot of stress at home or at school, that's another thing that's just important to evaluate. We talked about before that if you're worried about going to school because you get bullied all the time, that's not an anxiety disorder. That's fear that you're supposed to have in response to something that's real. So of course you have to see if that kind of thing is going on. Getting good sleep, obviously, so anybody, if they're down on sleep, they're going to be cranky, less focused, probably more anxious. And then diet, there's nothing in specific in diet other than just maintaining general well-balanced diet. Okay.
Can you go 2 slides back? Just
Sure.
I need
Oh, yeah, I think you guys can also get the slides if you want. And then, it's on YouTube as well, so I think it'll be like available for everybody afterwards, is that right? Okay, so you can always pause it. All right, so I'm gonna let Molly from my lab come up and just talk a little bit about one of the studies that we're doing. So I spend most of my time actually studying brain development in kids that go on to develop anxiety or ADHD. So I'm gonna let Molly sort of briefly talk about that, and then I can stick around for a while to answer questions.
Can you
I
explain?
just signed up for this today.
You just send out for
And I
today?
just got an email back from maybe you.
Oh, was it from Molly? Or maybe
Sure, so
Emily?
I can,
Can you explain, Chad, just what we're looking at in the study first?
Sure. So, one of the things that we have, that we're learning is that both kids with anxiety and ADHD, we think that part of what's going on are the parts of their brain involved in what they pay attention to. So even for kids with anxiety, we think that part of it might be related to, rather than being able to like stay on the task, their attention is sort of getting distracted by things that they're worried about or that they're scared of, right? And so, and then obviously with ADHD, we think also that there are challenges with focus or attention. And sometimes it can get tricky again to know if there's a problem with attention, is it more the anxiety or the ADHD? So this study is really designed to understand brain mechanisms that are, how the brain is functioning differently in a child that has anxiety, ADHD, or both, and then compared to kids that don't have either of those things. So the study that we're doing right now is for kids between the ages of 8 and 12 years of age, and they pretty much anybody, because they just have to have anxiety, ADHD, both, or neither. We do an MRI of them, which is just a magnet, and they can get a picture of their brain and maybe even a 3D printout of their brain if they do the study.
How sick is that?
The MRI is just a big magnet, so the only potential like discomfort would be from it's not small, but some kids can feel slightly like it's just narrow things. So just if they don't like tight spaces, it can be loud when they wear headphones, and then it's magnetic. So if they had any implanted metal or something like that, then obviously they could do it. Braces, they wouldn't be able to do it. Not because it would be dangerous, just because we can't see their brain if they have braces. And so it's 2 visits. We pay people to do it. And then we also do detailed psychiatric assessments. So our team, Molly actually is one of our clinicians, Logan, and we spend an hour or more with the parent and with the child, and we systematically go through different psychiatric problems. And we will send you a printout if you want of what the research diagnosis is that we get, along with potential referrals for where you can go if you want to continue to pursue that. And it's beyond free. We actually pay you $200 to do all this stuff. Yeah.
Are you doing this for kids under the age of 8, or how long are you doing this?
Yeah, so right now it's for kids that are 8 to 12. We'll probably be doing it for another at least 3 years. It's a 5-year study, and we're like year 2 or 3. We're trying to get 300 kids, and we have like 80 so far. The other study that we're doing right now is recruit people during pregnancy, and then we scan babies at birth to see if some of these changes are already happening right when the baby is born based on their risk for anxiety. And then we assess their levels of anxiety at 4 months, 14, and 24 months. And we even, for some of those kids, we're following them until they're 8 or 12, scanning them at other times to kind of look at the development of these attention-related brain systems. Just to give you a sense of where it's going, we also have one paper that we can send around if you guys are interested, where we designed a computer game to try to retrain the part of the brain that we think is functioning differently in the kids with anxiety. It was a small study. It was only like 15 kids, and they got better, but it wasn't well controlled. And so I wouldn't prescribe that to somebody just yet. But that's the idea: is to see how the brain is developing differently. and then see if we can target those particular parts of the brain rather than trying to just ask a bunch of questions to see if we can like guess what parts of the brain are functioning differently.
Is there the answer? What part of brain is not working? Do you know? How do you say, do researchers understand what part of brain is not functioning well in people with anxiety?
So, yes and no. So the question is about, do we know which parts of the brain are functioning differently in
Yes.
anxiety? We know a few things on average. So if you take 150 people with anxiety and 150 people without, we have some sense that there's a part of the brain called the amygdala that becomes active whenever you're scared. And maybe there's different ways in which that functions. I mentioned that right now we're trying to look at some other parts of the brain circuitry that we think are involved in what you pay attention to. Unfortunately, right now, this is not good enough where we could put you in a brain scan and say we're going to diagnose you with anxiety or not. And sometimes this is even advertised, like that people can hook you up to an EEG, right, or scan your brain and somehow tell you what psychiatric problem that you have. Right now, we do not have any of that, right? And I spend all of my time thinking about this. I would love it if this were the case, but it's not the case. Right now, the best thing we can do is do the psychiatric assessment and then keep trying to work on this stuff.
Kind of a little off topic, but is any of this linked to sensory processing disorder?
So the question is any of this related to sensory processing disorder? And that's not off topic at all, because yes. So sensory processing disorder, actually I have a close colleague, Rebecca Schwarzlos, that studies sensory processing disorder. And so things like either things are too intense, right? Like a tag or a sound or like visual things, or they're very distressing, etc. And lots of kids have this. It's not that as well recognized because it's not very well in our current classification system. One of the things that Dr. Schwarzlos has found is that the most common psychiatric problem that kids with other psychiatric problem that kids with sensory processing disorder have is anxiety disorders. It's also commonly linked to autism, although it's actually more common to just have anxiety rather than to have something like autism. Or you could just have a sensory processing challenge. And is this what you're talking about, this type of thing? So, these principles are sort of the same.
He kind of outgrew it, but he was diagnosed with it when he was younger.
Okay.
And when he'd actually like jump up and put his body on the ground because he wasn't intense.
So he's more sensory seeking.
Yes, that's your secret.
Yeah.
Because in schools, I feel like, because I was in school-based occupational therapist, so a lot of times I was, like, the kids with ADHD would have, like, would be recommended for OT because they don't do their school tasks. So, like in schools, if there's like a psychologist, what would they get OT to? Like if they just had anxiety?
So would OT be helpful for anxiety or sensory
Because they're
processing?
because nothing's like separate. Like even in life, like everything kind of is linked.
Well, so you're right that these things are.
For the sensory processing, I think. He did OT.
He did OT for the sensory processing.
Because like there's always that's the hardest task in school, like writing and focusing.
Yeah.
So if they have issues with attention, like they have OT issues too.
Yeah, and so the question is about OT, or the comment is about OT and overlap kind of in sort of, I guess one thing is that if you have a challenge in one of these domains, you're more likely to have a challenge in other domains. There's also sort of overlap in some of this stuff in terms of the treatment, right? So obviously, occupational therapists, you could say it better than I, but you're going to help figure out how to do particular tasks or sort of some other kind of a combination way you can do something.
Because as a parent, now I'm concerned. Because the teacher says there's like my son, so as an OT, like
So, just to, comment off of that, from my perspective, I do think that it's important, and it's hard, because care is kind of fragmented, right? Like sometimes, you're seeing a kid in a psychiatry office, and then also maybe have a therapist, and there's another parent maybe that's not there.
There's
and
just
the
symptoms
school.
like.
Sometimes it can be helpful, it can always be helpful to have everybody on the same page and communicating, towards like, the treatment plan with what's happening at school, because you're right, that like different people can have different perspectives, and if they're not all talking to each other, the kid can get different messages too, right? Like they can be told one thing from the parent, another thing from the teacher, and then the psychiatrist or the therapist is recommending something different, so it's a challenge. Yeah.
Non-pharmaceutical, non-over-the-counter medications for ADHD.
You're saying over-the-counter medicines?
Like not pharmaceutical medications to help with ADHD.
I don't know of any that have great evidence. There might be some out there that have sort of in really small studies where the kids aren't given placebo, or aren't given like a placebo-controlled trial or something, that people report that their symptoms are better. But there's nothing that I'm aware of that is convincingly effective for ADHD outside of the prescribed medications.
Are you saying SSRI?
No, for the question is about ADHD. So there are many different types of medicines for ADHD. The most effective are stimulants, like I said, like Ritalin, Adderall, and brand names. But there's also other medicines called alpha agonists, like guanfacine and clonidine. There's something called Strattera or atomoxetine. So there are different. Both of those latter ones are maybe about 60% as effective as the stimulants. So everybody's different. So it doesn't mean that a kid might not have some benefit from taking some vitamin or something like that. But on average, we don't have any strong evidence that any of that stuff is on average effective. I wish it were.
I was completely against medicating. I pretty much cried when I had to medicate.
Yeah.
But it has helped him at school and at home.
Yeah.
Someone described it as like there's like an orchestra in your brain that's just not playing the music, and when he takes his medicine, it kind of all comes together.
Yeah, that's a good insight.
Why are we hesitant to medicate? What are the known disadvantages?
So the question is about medications, and like when should we prescribe them? What are the, what's the reason not to? Obviously, these would all be discussions that you would have with your doctor. I don't want to like give general advice to people about medications. I think in general, if we like in anxiety, if we think we have a non-medication option that's effective, and there's not a lot of harm that like maybe it takes longer, but that's okay, then we try to do that, right? I mean, I of course, and I assume most people, like try to avoid medicine unless it's needed. The side effects for the medicines that I'm describing today are mostly minimal. Like SSRIs have very few side effects, and they're mostly mild, and they usually go away after the first few doses, and then you can always stop it if it doesn't. For the stimulants, the big one would be like decreased appetite, and sometimes you can have other kinds of things that pop up. But all these medicines have been around for a long time, and there's not any evidence that they're especially harmful. I mean, stimulants obviously are a controlled substance, and so you have to make sure that people are taking it as prescribed. The flip side of this whole thing, obviously, is that it's not like you either are going to give your child a medicine that has potential side effects or not. It's, are you going to give your child a medicine that has benefits or potential side effects, which often you can just stop anyways, or you can deal with it, versus like let them continue with anxiety or ADHD or something else, right? And so it's like growing up with anxiety or ADHD can be bad, and often it's bad. And a lot of the studies that we have that sort of look at, say, the brains of somebody with anxiety or ADHD is different, and then you put them on medicine, and it sort of normalizes it, right? And so you know, the question is, do you want your child to sort of like have their brain development for, 10, 15 years with, a way that we know is different versus maybe help them and, maybe they're not as hungry later on if there's something else that happens, right? So the point of all this is it's not just side effects or no side effects. It's, potential side effects of a medicine versus leaving a disorder untreated, which, I talked about some of the things that can happen later on. Actually, for ADHD in specific, there's actually a mortality benefit for people taking ADHD medicines. So I mentioned that, that people with ADHD are more likely to get into car accidents, they're more likely to, just, I don't know if it's getting into a fight or whatever it is, but they're more likely to die than people that don't have ADHD. And, it's not, I don't know the amount of the increase of risk, but the point is that when they're medicated, that risk comes back down to close to or at the same level of people without ADHD. That is that medicines for ADHD actually reduce the risk of dying, and they reduce the risk of starting drugs as well. Because the other thing is that people that are impulsive from ADHD are more likely to start abusing a drug. So again, there's both sides of the coin, and you just want to make sure you're just thinking about all that stuff as you're making these decisions. Yeah. But, so go ahead.
I just had a question, like with an ADHD brain, I know we've talked, or I've heard before about like the brain age of like, the child might be 10 and then your executive function or organization of that brain of a child with ADHD is, a couple years younger. Is there a correlation to like how kids with anxiety process their emotions? Is there kind of a discrepancy between like their chronological age and like the capability of their brain and that kind of?
So the question is about, the statement was that people with ADHD might look like their attention is sort of functioning several years younger than somebody that doesn't have ADHD. And the question is, could you think of anxiety in the same way? I would say yes. I think that maybe when kids are younger, there's a benefit to thinking about it that way. But I would say it's in both cases it's that they're functioning differently. Not just younger, they're functioning differently, right? So I don't think you could easily take like an 18-year-old with ADHD and say, well, their attention span is like, maybe you could. Maybe you could say something like that. But so yeah, I think in the same way you can say sort of the same thing for anxiety.
I'm thinking more along the lines of when you're trying to explain that reassurance or trying to understand how they're processing something to be able to kind of give them this positive self-talk or, just that redirection or the redirection back to, this is something that seems to be common, and I think in my own personal case, I started to use words and now my child starts to use like how they're feeling, and can identify those triggers. But I also think there's a little bit, I don't know, of a little bit of more, it's harder to put the point on it for a kid going through that versus a generalized kid that hasn't gone through that.
Yeah, that's a good point. And the other thing that you brought up that I like, and I'm glad you brought up, is I also think it's really important to tell kids exactly what you're thinking and what you're noticing and explaining to them all the stuff that I've explained today as far as what is ADHD in this case, like what does it mean? Like it means, this is harder, this is harder. And then for kids that end up going on medicine, like I want them to be able to describe like what's their brain like when they're on the medicine versus off, and what are they like and when this situation, so that they can eventually learn like to make the decision for themselves, like do I function better this way, or does it depend on the day, or something like that, right? And the same with anxiety and all of the stuff about exposure. So I think it's helpful to tell the child this is what we're going to do, right? Like we're going to go through this exposure stuff, and I'm not going to reassure you because I'm noticing this, and this, right? Rather than like kind of not explaining to them all the stuff that's going on. I think that psychoeducation and that self-knowledge is really important.
Well, I was going to say, kind of right along those lines, I was going to add to what you were saying before about medication, but that's kind of it. I'm coming at it from a different perspective. A number of my kids are older and have gone off to college, and I have a couple that are home. And between them and their friends, I've seen now the difference between trying to help an 18-year-old then all of a sudden who is diagnosed at college then with ADHD and trying to manage appointments and medication and all of the things that they're trying to do on their own away from home is exponentially more difficult than a child. And I'm just saying, you know, if there's a chance that they'll ever be medicated or want to be medicated, it's 1,000 times easier to have them go through those motions and try a number of different options and a number of different things while they are at home with you, so that when they do go away to school and are not at home with you anymore, they do know already what they're up against. Because you get an 18 or a 19-year-old with ADHD, and not only are they tanking their classes because it's hard, you know, to manage, but try and get them to go to their appointments or their checkups or just getting their prescriptions refilled. It's just a lot harder. I just wanted to throw that out there too.
Yeah, thanks for that. So the comment was for the people on YouTube, it was that it can be easier to recognize, in this case, ADHD and consider treatment younger before they say go off to college, when like organizing all that stuff and figuring out how to manage it can be more challenging. I think that's exactly right. And, you know, to just kind of riff off that a little bit, you know, also for anxiety, right? Like that's why the teaching of sort of independence and like not having the child sort of rely on you to kind of reassure them, or teaching them this process of the gradual exposure, like all of those things can be kind of lifelong things that they can use when they get older. So I agree with you that managing things when they're younger is helpful. The other piece of what you're bringing up is that you know, ADHD is supposed to start when you're young, or at least we used to think it was very young. I think that's mostly true, but if your child is very smart, then they can get by without being able to focus very well, right? And so they can kind of not be super evident, but then things get harder when they get into middle school or high school or college, and then the fact that they can't focus suddenly starts to get in their way, right? But if you can recognize that earlier, and at least then they know what to do. Maybe they don't need a medicine when they're, you know, in middle school or high school, but at least knowing what it is and knowing what their options are for when it does become impairing, it is really important. So, yeah.
Coming onto that comorbidity piece that you were talking about, is there a concern when medicating that the stimulant can increase the anxiety symptoms? Is that something that you guys consider, or?
Yeah, so the question is, if there's comorbidity, could the stimulant make anxiety worse? It is possible. It's not, I don't think it's super, it can go every single way, right? It could make the anxiety better, it can have no effect on it, it can make it worse. I think that it's really difficult to know in advance which way it's going to go. And in my experience, a lot of times the anxiety gets better. You know, just because the kids can organize their thoughts better, or they're not overwhelmed because they know that they can focus. But there are some kids where it gets worse. What I, again, my personal sort of opinion is, though, is not to not try that type of medicine in a kid because you're worried that their anxiety is going to get worse, because you know, you don't know, and you might be denying them the opportunity to you know, to have the best possible treatment. But you know, you really, for that kind of thing, really need someone to sift through what the symptoms are and you know, figure out what might be primary. Sometimes you have to start with anxiety first, and it's more overwhelming, and then treat ADHD, or vice versa. ADHD treatments work a lot faster than anxiety treatments, so sometimes that's the reason. So the point is that it's a very kind of person-specific and complicated thing, but it can go any way, and I you know, I would still consider that route for sure. Yeah.
Why would you prescribe Ritalin, or it's that category, versus Adderall? What's different between the two? Why would you go with one versus the other?
So Ritalin versus the mixed amphetamine salts, or Ritalin versus Adderall. Mm-hmm. Why would you prescribe one or the other? So, you know, The truth is that there's not a huge difference between those two, and a lot of times it's just sort of preference or comfort of the person that's doing the prescribing. Maybe there's slightly fewer side effects with Ritalin, sort of methylphenidate based ones, but again, it's so individual specific. Sometimes if a person has a side effect from one, then we'll try them on the other and to see if that one will work. The bigger difference for the stimulants, even more I think than that, is there's long-acting versus short-acting, there's intermediate acting. All the long-actings work in different ways and sort of have different releases. Some will release a pulse in the morning and a pulse in the afternoon. Others are smoother. Some of them, so it's, there's all sorts of different formulations, and so that can be a bigger difference maybe than Ritalin versus Arrow.
So, my son just started seeing a therapist for his anxiety, and I don't know if she's doing CBT on him. And is it, like, when I drop him off, I kind of give her things that are causing anxiety for him to talk through. So, does a CBT therapist just take over the therapy sessions and know what to do, and I don't have to say what's going on? So, I don't think I have a CBT therapist.
Well,
So I'm giving her stuff to talk about.
No, so lots of points there. So first, no, the therapist can certainly get information from parents, and that's often helpful. So even like in the manualized version that I said, yeah, most of the sessions are child only, but then there's specific sessions that are just for the parents. So like here, because kids might not always tell you all of their fears, or they might not describe it in all the same ways, right? So it's not.
I went in at first and told
Told her all the stuff. But and also, yeah, so that can be totally reasonable. And the other thing is sometimes helping with the parent involved to help with like the exposure type stuff. That depends on the age of the kid too, and all those other things. Usually the younger the child is, the more you want to involve the parent. But it is fair to say to the therapist that you heard this speech about how cognitive behavioral therapy was great, and is that the particular type of thing that this person does? And I think you could ask the person, and I would say 90% of the kids that come in to my office that are getting therapy are not getting exposure therapy, right? So it's very common. That being said, if you could ask the person, like, hey, somebody mentioned that this is really effective, this idea of exposure and having a really particular plan that's written out in advance, what you're going to do week to week. Is that something that you think might work? And how could we potentially do that? Or if not, it's also totally fair to say, hey, especially if it's been like 4 or 5 visits, right? Like, hey, how are things going? And can you explain? There should be some privacy between the child and the therapist, right? So you don't want to know all the details about what they're talking about, but they should at least be able to tell you what the plan is, right? Like, what's the specific way in which we're going to help this child's anxiety get better? And there are other approaches, but again, I would recommend CBT with exposure far and away, especially first, and especially if there's not some reason not to do that. The biggest reason would just be the child's too young, or if they had maybe some like cognitive problem that prevented them from being able to do something like that.
How important is the privacy if the child is young? So say, how old is Richard? Like if the child is younger and you feel like they need a parent with them, so do they still do the sessions without the parent?
So how important is privacy and how important is it to have the parent in there? So it depends on the goals of the therapy, right? And the age of the child, certainly. For really young children, actually, a lot of it is just training the parent, actually, to essentially be the CBT therapist and do the exposure like during the week, right? Rather than like try to explain the whole thing to a 6-year-old, right? But I think for most kids, for most therapy, they usually involve some time just with the kid, yeah, just the therapist. And you want the child to feel like they can say whatever, right? And sometimes there's things they just don't want to say in front of the parent.
I
I'm sorry, I think this will need to be the last question for that time.
Yeah, I just missed at the beginning. You have the lab and you also have the clinic. Can we have the context of the clinic?
Sure. Yes, it's, it's Washington University. We probably can send out the main number for that. This is our child and adolescent clinic. I will say there's fairly long wait list.
There's a wait list everywhere.
If you email me my emails right there, I'll send it to you.
Yeah, thank you so much.
Yeah, I'm happy to.
Thank you.
I can, if you have a question afterwards, I'm happy to
Yeah.
share. I don't wanna, we can chat afterwards if we need to.
We can do one more, but
All right.
it's after 8 now.
I was just wondering, so you talked about like what you would recommend. Is there anything you would actually warn us away from, whether it be for the anxiety or ADHD that you've heard people try and you're just like, stay away from it, it's a scam, or, it's something like that?
Yeah, there's lots of stuff that's
Yeah.
that's out there that I feel is, it's not proven,
Yeah.
right? And so there's lots of things that have to do with getting imaging or doing, like the MRI or the EEG or other sorts of things that are there's just no science to back it up, right? Or other sorts of, I don't want to name any particular sort of entities, right? But a lot of other sorts of things that we're not talking about today, like very complicated sorts of exercises that people go through that are just, there's no evidence for it. I think stick with the bread and butter stuff that we kind of know works well, which is mostly this. All right, thanks everybody.